Hello, I'm Dr. Hafsa, and in this video, I'm going to walk you through some slides on bowel obstruction. So what is bowel obstruction? This term typically refers to a mechanical blockage of the bowel whereby a structural pathology physically blocks the passage of intestinal contents. Here I'd also like to mention that around 15% of the patients reporting to the hospital with acute abdomen are found to have bowel obstruction, which shows how important it is to identify and diagnose such patients timely. I'm going to classify our topic into four types. The first is mechanical or dynamic obstruction, in which the bowel is capable of contracting normally proximal to the site of obstruction. The second is non-mechanical or adynamic obstruction, in which the peristalsis may be absent due to neuromuscular failure, or it may be present but in a non-propulsive form. Let's see how the food moves through the intestine in a normal propulsive manner. Please excuse my drawing skills. Okay, so let's assume that this is a segment of the gut. I'm marking this as PS, the propulsive segment, RS, the receiving segment, and here inside this is the food bolus. First, there is an area of contraction behind the food bolus inside the propulsive segment. Here the circular muscles contract whereas the longitudinal muscles relax. This in turn pushes the food forward into the receiving segment, and this is how the food is moved through the intestine in a wave-like pattern. Thirdly, we can classify it on the basis of anatomy, so it can either be a small or a large bowel obstruction. And fourthly, we can classify it on the basis of nature of presentation, so it can either be acute or chronic. In acute cases, small bowel is usually involved, and it is associated with sudden onset of severe colicky central abdominal pain with early vomiting and constipation. This can also be followed by abdominal distension. The chronic condition generally involves the large bowel with lower abdominal pain and absolute constipation. Now let's focus on the etiology or causes of bowel obstruction. They're also divided into dynamic and adynamic causes. To simplify them a bit more, I further subdivided them into three subtypes: the intraluminal, intramural, and extramural causes. The intraluminal causes arise from within the intestine, for example, fecal impaction, foreign body, pezores, and gallstones. Pezores are concretions of indigestible material like hair. The intramural causes arise from the bowel wall, for example, strictures or malignancies. Strictures can be seen in Crohn's disease. The extramural causes extend beyond the bowel wall, for example, adhesions and bands, hernias, volvulus, and intussusception. We're going to learn about them shortly. The adynamic causes include paralytic ileus, mesenteric vascular obstruction, and pseudo-obstruction. Here we can see how adhesions actually look like. So the adhesions can be in between the intestinal loops or between the intestine and the abdominal wall. Adhesions are basically bands of scar tissue that connect two internal body surfaces, and people who have had multiple surgeries in the past are more prone to develop adhesions. In intussusception, a part of the proximal bowel folds into the distal and adjacent segment of the bowel. As seen over here, the small intestine has folded inside the large intestine, whereas in volvulus, a loop of the intestine folds around itself and its mesentery. This generally occurs in elderly patients, patients with chronic constipation, and patients with neuropsychiatric disorders. Now I would like to draw your attention towards the pathophysiology of bowel obstruction. We can simplify it by looking at what happens proximal to the site of obstruction. Whenever intestinal obstruction occurs, the peristalsis increases to relieve the obstruction, but when this does not occur, the peristalsis ceases at some point. The fluid proximal to the obstruction accumulates and collects, in which the bacteria multiply. This results in a flaccid, paralyzed, and a dilated bowel due to the inflammation of the bowel wall. Whenever there is inflammation, we all know that macrophages accumulate and they release cytokines. To further aid this process, there is an increased release of nitric oxide and reactive oxygen species. Now we will see what happens at the site of bowel obstruction. As we discussed before, whenever the bowel wall is inflamed and dilated, the intraluminal pressure exceeds the bowel wall's venous pressure, which in turn impairs the venous return. Now when this happens, there is congestion and edema of the bowel, which further causes dilatation and ischemic injury, which in turn blocks the arterial supply and perfusion, eventually stopping the peristalsis and leading to necrosis. This in turn leads to gangrene, and bacterial toxins are released into the blood supply, and there is mucosal damage also because of the reactive oxygen species. This all leads to sepsis eventually. So far we've understood the basics of our topic. Now let's see how to diagnose a patient with such a condition. Starting off with a history, the onset might be acute or chronic. There might be a history of bleeding per rectum, constipation, weight loss, anorexia, or changes in bowel habits. There can also be a history of prior surgeries. On examination, we can find abdominal distension or a mass. This can also be associated with abdominal tenderness or guarding. On auscultation, we can find high-pitched or tinkling sounds. Moving on, let's have a look how the blood profile might look like. So if we get a complete blood count done, we will find raised white cell count, which indicates infection, raised hematocrit, which indicates hemoconcentration. Now this occurs due to the fact that the patient has reduced intake, there's decreased absorption from the gut, and the patient might also be vomiting. Now this triad leads to volume depletion and electrolyte imbalance, which is generally hyponatremia and hypokalemia. This in turn leads to raised serum urea and creatinine. This also occurs in cases of dehydration. If we get the LFTs done, we will find raised serum bilirubin and ALP, that is alkaline phosphatase. Serum amylase is a non-specific indicator, but it may be raised in some cases of small bowel obstruction. Serum lactate can be used as a good indicator for bowel ischemia. I would highly appreciate your feedback in the comments below. Please find the link to the second part of this video in the description box and subscribe for more videos.